Yeah, yeah.
10:05 it is. We should start
Certainly.
on time.
We should, we should.
81 students are there.
Yeah, yeah.
Fine. Yes, over to you, Saili.
Yes,
Start.
we'll start. Okay, yes. Good morning, everyone. I am Dr. Saili Dabirao. I am an assistant professor at KMSK GMC Chandrapur. I warmly welcome you all in today's scholarly Sunday session, organized by Postgraduate Education Psychiatry Education Committee of Psychiatric uh, Psychiatric Society of Western Zone. In today's session, we have our topic as Sketch 25 Score High. So, in this topic, we are going to discuss about 25 diagrams, which will be helpful for your exams, both theory as well as practical. So, with this, I would like to welcome our president, Dr. Bhave sir, and I'll request Dr. Bhave sir to have his introductory speech, please. Thank you, sir.
Yeah. Thank you so much, Saili. I think today Dr. Sushil Gawande and his team have come up with one more of those very important and exciting programs. I mean, that he has been having for the past 4 or 5 months. I think this idea about discussing diagrams is a wonderful one. I mean, if you think of it, because I mean, being students of neuroscience, we know that diagrams help in many ways. I mean, they improve our visual memory for something. They help in a kind of visual organization within our own mindscape. Complex things tend to get simplified. I mean, when they're shown in diagrams, the relationship between different facets of neuroscience or, I mean, neuropsychiatry. I mean, they get clearer in the student's mind. I mean, we have an experience for many, many decades that whenever, I mean, we scribble diagrams while learning something, I mean, it's both a verbal memory and a visual memory that together synergistically help us in recalling things better. So I think it's a great idea. And selecting 25 diagrams must not have been an easy process, I can imagine, because I mean, there are so many potential diagrams, but then picking up the 25 most important ones, which could really help the students not only do good in exam, but actually comprehend the subject better and remember things better. I think that's very important. So congratulations, Sushil, for again coming up with a wonderful idea, and your entire team, Sri Lakshmi, Saili, who I'm sure have worked hard for the program. And I'm sure, I mean, the students, after 1.5 hours, the students are going to be enriched with 25 new facets in psychiatry, maybe revised, maybe something new for them. So thank you, Saili. Over to you.
Thank you, sir. I now request Dr. Gawande sir to have his few words about the session. Thank you, sir.
Thank you, Saili, and thank you, Bhave sir, for all those nice words. Yes, as an examiner for a MD theory examination, I would expect diagrams in some of the questions. Uh, for example, if somebody is writing about psychodynamic theory given by Sigmund Freud, I would expect them to draw a diagram of id, ego, and superego. So in psychiatry, there are such must to write diagrams which are expected, and without those diagrams, your theory paper would be inadequate. And in addition to these theory-based advantages of the diagram, there are definite advantages which Dr. Bhave has mentioned. So without a further ado, I request moderators, Dr. Saili and our faculty, Sri Lakshmi. Both of them are going to act as a moderators as well as faculty to go ahead. I am thankful to all organizing committee of this committee for joining this program and giving best wishes to Saili and Sri Lakshmi. Over to you, Saili. Thanks.
Thank you, sir. Thank you very much, sir. Now I would like to introduce Dr. Sri Lakshmi ma'am. She is an associate professor at Department of Psychiatry in Nagpur. Madam is known for her skilled and resident-friendly approach for teaching. I am looking forward for this session myself, ma'am. Thank you very much, and I like to request you to start the session. Thank you. Ma'am, you are not audible, ma'am.
Thank you so much, Saili, for the kind introduction. And thank you, Sushil sir and Bhave sir. As always, Sushil sir, with his creativity, has brought in a little bit of art into the subject as well. Sir is well known for that. So, this, I believe, we all know a picture speaks more than 1,000 words. So, like everybody, all our seniors have very rightly pointed out that whether it is the exam paper or whether it is about understanding the subject, when you look at a diagram, rather than reading pages and pages of text, things get into the mind much more simpler. Many of us are multi in terms of our sensory modalities of learning. So, visual modality is something which everybody usually picks on. And of course, from the exam perspective, which is what we have tried to bring to you today, because like Bhave sir rightly put, there are hundreds of diagrams if you open the textbook. And it's really difficult to, in 1 hour, put everything together. So what we've tried to do is kind of give you hints or give you an idea of different types or different kinds of diagrams also, that you can, these are all only for educational purposes. Some of them do have copyright issues, so I request that whatever it is, you take it in that sense only. And we have tried to put in the references wherever we have taken specific references. Rest of them are of course from the main textbooks. We've put the reference at the end. So we are trying to give you an idea. And as a resident, I believe diagrams are very, very useful in exam, because we all know how short of time we have when we are writing. So instead of writing an entire page of text, if you just put in one diagram, it's very good for the person who's correcting, and they understand that you know about the topic as well. So from that, we've tried to make this interactive. We like you to interact with us on chat. So the picture will be displayed. We might ask some questions. We'd like you to give us the answers on chat. We are reading here, or you're welcome to turn on your mic and answer as well. So we'll begin with what I think Gawande sir very rightly referred to. I'm sure you all know which this is. So maybe what you can answer in the chat is which theory. Freud had named the theories of mind. So if someone can just give some answers, you can unmute and answer, or you can answer in chat. Id ego, superego was one, and conscious, preconscious, unconscious was one. Any answers? Yes, topographical theory is which one? Structural and topographical. Can you just give which one was what? Thank you, Abhinav and Shreya, for the quick answers. Okay, I'm not, because if we dwell too long on each slide, it's going to take time. Yes, someone said unconscious, conscious, preconscious, topographical. Right. So you know that what the other one is. You're all the MCQ generation. So this is a very, very simple, very easy. And like sir said, in any questions related to psychodynamic theories or anything related to Freud is again something that keeps coming up in basic sciences paper. So as LAQ, as SAQ, even when you're discussing defense mechanisms, this is a very, we've taken a very simplistic picture. There are many images of this if you come across. The textbook also gives a little more complex image, but this is something that very quickly you can just write down in your paper when you're answering these kind of related questions. So this is our mind as imagined or picturized by Freud in his theories. What is this a diagram of? If anybody can respond. Yeah, we have Wonder Woman saying Maslow hierarchy of needs. I don't know who that is, but thank you. Yes, so this is, we all know this is the hierarchy of needs, going from the basic physiological needs all the way up to self-actualization. And this was indeed given by Abraham Maslow. So this again is one of the commonly asked questions when we are talking about theories in psychology. So a very simplistic way to, instead of writing paragraphs on each of this, you just put on a diagram. I think this covers a lot of the things. So about the theories of motivation, that's where this would come in. stages in the hierarchy, and anything related to human behavior. These are the aspects that can be discussed in exams most often as SAQ, but it could be an LAQ also if you're looking at theories of motivation. We come to the next one. Which theory is this? Operant conditioning. Okay. Can anybody remember who gave this theory? Yes, B.F. Skinner. That's right. So I've seen many residents getting confused whenever you ask about learning theory and operant conditioning, about what is reinforcement and what is punishment, decrease, increase. So this diagram we chose specifically for that purpose because it makes it very simple to remember. So whenever you think of reinforcement, right, reinforcement is always associated with increasing of a behavior. Whereas if you're thinking about punishment, it is with reducing a behavior. When we talk about these theories, it's better we don't use good behavior, bad behavior, rather than giving that term. It's just the desired behavior or the behavior that we are looking at. So if you are looking to increase the behavior, it would be reinforcement. Decrease the behavior, it would be punishment. And what are you doing at that point in time? If you're giving a stimulus, then it is positive. If you are removing a stimulus, it is negative. So if I am giving a stimulus and I am trying to increase a behavior, it becomes positive reinforcement, right? So I would obviously give something pleasant if I want to increase the behavior. So that would be a reward. Okay. If I am looking to increase a behavior, but I'm removing something away. So if I have to increase a behavior, I need to remove something which is aversive or which is not good for the person, right? In which case the behavior would increase. So this is what would be avoidance or escape. Okay. Punishment, on the other hand, is adding a stimulus to decrease a behavior. This we are all very familiar with from childhood. We've had to deal with it, right? And removing a pleasant stimulus to decrease a behavior would be omission. So this is the basics of operant conditioning. This one diagram more or less says it all. Okay. And if you remember it in this way of increase behavior, decrease behavior, add a stimulus, remove a stimulus, you are least likely to go wrong when you present this. Right? So this again in questions that we have, it's all the different types of learning, the understanding of behaviors. Clinical application of operant conditioning is also very, very important when we are talking about exams. Okay. What is this? Any response? The name is right here. Yes, stages of grief, grief reaction. So you have DABADA is usually how we all remembered that as a short form. Denial, anger, bargaining, depression, acceptance. And this was given by Kubler-Ross. Yes. So again, a very simple way that you can put in the stages. This again is something which can come as an SAQ, and it helps you understand the process overall of grief or loss when we are talking about the grief reaction. Right. Saili, over to you for the next one.
Okay. Yes. So our next slide is showing ABC. Can anyone? Yes, it is CBT model, and the name also suggests ABC of CBT. So what does ABC stand for? It is A is activating event or a situation which activates what? Activates the cognitive distortion or negative beliefs related to that condition or the situation. So B is belief they are not very healthy for that individual, and that leads to consequence, that is C, which is again a behavior secondary to the belief which was originally started because of the activating event. So this ABC in CBT, it is very crucial to understand. Why? Because we have to then, what is D? D is a dispute. We dispute the beliefs. We dispute B That is belief which are not healthy, or in short, we can call it as cognitive distortion. So with an example, if we try to understand, if one of my friend doesn't greet me and just moves without looking at me or noticing me, I would start having thoughts regarding that event, which the event would be an activating event, which was my friend did not recognize me or wish me. Then my belief would be that he is angry with me, or he won't be able to talk to me, and mm, he is not my friend anymore. I'm worthless, whatever the cognitive distortion I'm having. So that belief would give rise to consequences, such as I would not talk to the friend, I would block the friend, and these are the consequences which would be harmful to me and my relations to my friends. So what is D? D would be the distorted origin, and likewise we'll go ahead with the CBT therapy. So I have provided a reference of an article which explains this in detail. Textbook usually give you theory about the CBT, and this model especially would be explained in the CBT notebooks proper. We'll be sharing the PDFs after the session. Yes, someone has asked, ma'am, could you please explain D? So D is dispute. We are challenging our beliefs. So if I'm having a belief that I am no worthy of friendship with the person I met, then I have to dispute that belief. Is it like that? Could that be it? Could that really be it? Is there any explanation for any other alternative explanation for that? Then that is a dispute. We are disputing the belief which is distorted. I hope I'm clear with the question. Yes. So with this, we'll go
One more
ahead
for the
with the next
residents.
slide.
Who is the person who gave us CBT by the time we move on to the next slide?
Mhm.
Full name, please. There is more than one Beck in psychiatry. Yeah, thank you. Yes, it's Aaron Beck. Siley, next.
Yes. Next slide. Yes. So this slide, can anybody tell which is this diagram? What does it suggest? Yes, it is a limbic system with all the structures notified. This diagram is from our textbook, that is CTP. So limbic system, the name was coined in 19th century by Broca, and he coined that name because he thought that it is a border or edge between the cerebrum and brainstem. So limbic system consists of multiple structures. Now different textbook have different structures, including in the limbic system, but standard textbook, that is CTP, has mentioned all these structures. So what does it consist of? It is a cingulate gyrus here. The cingulate gyrus then continues further to parahippocampal gyrus. Further, after that, there is thalamus. Next slide, I'll be explaining the structures. So this picture would be a simplistic diagram whenever you are in a hurry to write your LAQ in your exam. So you can just arbitrarily put these structures in your brain area and label the structures accordingly. So this one here is cingulate gyrus, which also continues into parahippocampal gyrus. Above that, arbitrarily, there will be hippocampus. Uh, Proximal to hippocampus, there will be amygdala. Above, we have thalamus T, and below arbitrarily the below thalamus there would be our hypothalamic structure. So with all these structures independently are responsible for certain uh, functions which we experience, and they are responsible for functions like emotional regulations, memory consolidation, then olfaction, and autonomic and endocrine regulation. I'm sure you are going to read it further in detail from the textbook. So in limbic system itself, there is a circuit called as Pape's circuit. Can anybody tell me what is the role of Pape's circuit here? Yes, so memory processing and memory consolidation is done in Pape's circuit. So Pape's circuit starts with the hippocampus. From subiculum, the information goes to mammillary bodies uh, via phonics. Okay. So from mammillary bodies to mammillothalamic tract, the information goes to the thalamus, that is anterior nucleus of thalamus. From anterior nucleus of thalamus, the information then is transported cingulate gyrus. Cingulate gyrus bifurcates the information. One goes to parahippocampal gyrus, and from parahippocampal gyrus back to the dentate gyrus of hippocampus, which is a receiving end of hippocampus. The other information goes also to prefrontal cortex. Here it explains our judgment and judgment regarding our memory. So this is a Pape's circuit, and uh, why is it important to know in your day-to-day practice as well as your observation? It is very much enlightening to understand these circuits, and also in theory, if you are getting limbic system as LAQ, which is most frequently asked question as far as I know. So you can just draw these diagrams and save your time completing your LAQ answer. Okay.
I think someone had just put up a question in the passing that
So
need
we'll
to
move ahead with the next.
do we need to draw this diagram, or a flowchart will do? When it comes to neurobiology, I think drawing a diagram might work to be more effective than a flowchart, because it essentially says, like, this is a very simplistic form that Siley, this is a diagram that Siley is drawn. So without much time, as you can see in the exam, the one we showed you previously was the textbook drawing, of course. But even in this way, if you can just, with a basic idea, just show the brain which approximate region the area lies, that in itself tells the examiner that they are very much aware, you know where things are. Whereas in a flowchart, you can only just name the parts. So I think that would be the difference when it comes to the neurobiology diagrams. Flowcharts are definitely useful. We'll come to that a little ahead in the session. Over to you, Siley.
Yes. So as ma'am said, your diagrams, it doesn't take much time, and you can just draw and explain yourself. So what is this diagram? Yes. So one is very basic IB Singh referred diagram, which you have already studied and practiced in your first year. And the other one is more uh, good with the understanding point of view. So basal ganglia, it consists of caudate nucleus. Here, the right side diagram, I have showed caudate nucleus with lentiform nucleus, head, body, and tail of caudate nuclei. And at the end of the tail, there is a amygdala structures, which we also seen in limbic system there. Now, what is lentiform nucleus? So lentiform nucleus is a combination of putamen and globus pallidus. What is striatum? Can anybody tell me? What we always get this term striatum while referring the basal ganglia or limbic system or behavioral problems. Yes, so striatum is it is a combined structure of caudate and putamen structure. So basal ganglia, they consist of caudate nucleus, then putamen, then globus pallidus. Globus pallidus is again divided into internus and externus. Then thalamus and subthalamic nuclei, as well as substantia nigra. So basal ganglia, why is it important? Basal ganglia is important in, as you all know, direct and indirect pathway of motor system. So motor movement regulation, fineness of the motor movements, and through structures like nucleus accumbens, it is also playing important role in reward system of our brain. Again, emotional regulation can be also seen regulated via basal ganglia. The textbook, of course, would be giving you in detail mechanism of action about direct and indirect pathway as well as the nigrostriatal pathway. So all these three pathway are important in movement regulation. Uh, so
Yes,
and in reward system,
also in the various disorders, whether it is movement disorders or like sir has very rightly said, हमारी treatment की गलतियां बताता है, which is where
yes,
we have our side effects as extrapyramidal symptoms that is also related to that, and you have movement disorders like Parkinsonism, Huntington's. All of this is related to the direct indirect pathway of basal ganglia.
pathway. So as sir and madam has pointed out, EPS, which we see in our treatment, is also explained by this direct, indirect, and nigrostriatal pathway. You can get LAQ on basal ganglia or Parkinson's or EPS, any movement disorder. You can explain this condition with the help of basal ganglia as well as direct, indirect pathway. For direct, indirect pathway, though, you can draw simplistic diagrams or structures or flowchart would work. Next slide, please. This is very familiar diagram and very I think close to the hearts of UGs. So this is the simplistic diagram. When once we understand the blood flow of brain. Yes, it is circle of Willis, and we have our theories, right, regarding the circle of Willis. So this is a basilar artery which bifurcates into posterior cerebral artery. Then it gives branch, which is posterior communicating artery. From in front, internal carotid artery is divided into middle cerebral and anterior cerebral with the communicating branches as shown in the figure. So it is important in questions like lobes, when you are asked about frontal lobe, parietal lobe, temporal lobe, like that, the LAQs come. For that, you can just show this diagram to notify the blood supply of brain. So this is from IB Singh, the diagram, very simplistic. This one is more vivid, and I think 3D effect puts more understanding component in the diagram. Okay,
This also
so
helps you understand when you're thinking about stroke, cerebrovascular
yeah,
accidents, and the effects of that is something that we often. So, depending on which artery or which vascular supply is involved, which region of the brain is likely to get affected, hence, what kind of symptoms. So, this even in your practical exams, when you're coming across cases of neurology that you have to present, you have to localize the lesion or the area. This is very helpful for you to understand, because sometimes residents get confused when you have across That is facial on one side, the body symptoms, hemiplegia on the other side. So having a very basic understanding of the circle of Willis and the brain supply is very helpful when you have to localize lesions and talk about it in your practical exams as well.
Okay. So, yes, so we'll move ahead. This is a diagram showing what are the structures. So there are two oval shaded areas and they are connected with the, yes, so these are the speech areas, that is Broca's area and Wernicke area, which is which motor, sensory, yes, which one is motor, which one is working Wernicke. This is very basic, but still for the sake we can, yes. So Broca's is motor and Wernicke's is sensory speech area. They are connected by this arcuate fasciculum. So you should note the anatomical position of both the speech areas while talking about speech and disorders of speech, and uh, the topographical relations with the areas. Then, why is this important? This would be helpful in understanding the aphasias which we come across in neuro examination or neuro cases while being in practical exams or in a theory question. So, types of aphasia. This diagram I personally like because it very vividly shows the types of aphasia. So, without wasting much time, I'll be explaining this diagram. So, we divide the aphasia, I mean, we diagnose or come to the conclusion of aphasia diagnosis with the help of these three components. That is the speech fluent? Can the person understand or comprehend the speech which he is receiving? And can he or she repeat the speech? So, accordingly, this gray line is suggestive of no, that is no fluent speech, no comprehension, no repetition, then it is a global aphasia. If there is no fluency, but patient comprehends but cannot repeat, then that is a Broca's aphasia. Accordingly, transcortical aphasias, if you are noticing, they are with an intact repetition. So all the transcortical aphasias, patient retains their ability to repeat the speech. So what is transcortical basically means that the speech areas itself are intact, but the connection around them or whatever the structures they connect the areas, they are not working very well. So this is the diagram showing aphasias and types of aphasias. I'll move ahead, I guess.
Yeah. So this is something that I have dug up from the time that I had done my residency, but I think something which is very useful to remember. It's not a very representative diagram, but per se, if you're looking from a 3D or a location perspective, but more from an understanding. This is something that usually as residents we are often asked, or we need to remember which area of the brain is responsible for what. Of course, there's a lot of overlap because of the connections, but broadly, if we can look at, it's easy to remember this way of prefrontal cortex, where you have executive functioning predominantly, attention, concentration, emotions, impulses. So in prefrontal, again, there is division, of course, but this is a broad area. So you have the obsession, compulsions, ruminations, worry, and negative symptoms. All of this is associated with prefrontal cortex. Similarly, here you have the basal forebrain, which is responsible for memory and alertness. And if you go further inside, then you have the striatum. We've already visited with the basal ganglia. Striatum nucleus accumbens is going to come further ahead when we're talking about the reward pathway. It also does have effects in delusions, hallucinations, pleasure. You have the thalamus, which is the pain sensory relay from the cortex responsible for alertness. So, in one shot, like this was something that I found very helpful during the exam. This is from Stahl's actually, one of the initial diagrams in Stahl. So, as a quick revision, if you just want to hold one paper instead of going into functions or into parts in depth, just as a quick recap just before the exam, something very, very helpful to go through, right? Okay. Which receptor is this? Yeah, I can see people saying GABA. Okay. So what is unique about GABA as the neurotransmitter? Or what is it about GABA's functioning, or if you look at from all the circuits? Inhibitory. So this is the one neurotransmitter which we always associate with inhibition. Of course, it's a very tricky one because very often it is present in the interneurons or the connectivity, because of which it plays a lot of role in how other neurotransmitters increase or decrease. So, but overall, if you can remember, GABA is always the inhibitory one. Of course, you have the GABA A, GABA B. We've tried to put a very simplified structure of the GABA receptor. So in your basic sciences exam, the neurotransmitters, so brain regions, we went through some of the most commonly asked ones. There are more, like you have the various lobes also, but we tried to cover the little bit of the difficult diagrams. So like that, among the neurotransmitters also, you have all of them where the receptors can be asked. But GABA is one of them where you have the subunits and the parts. So you have the benzodiazepine site in the GABA receptor, right? You have the site for the barbiturates. So in a simple way with a short A, you can just describe the various subunits as well as the sites in just one diagram, right? And questions related to drugs as well. When you're talking about mechanism of action of medications, benzodiazepine, sir has put in chat as well, zolpidem, barbiturates. So just this one diagram for and with the necessary labeling and a line about the mechanism of action will complete that instead of writing paragraphs on it. Yeah, so this is the GABA receptor, it's be gone. What about this? A close associate.
सेशन चल रहा है कि रिकॉर्डिंग
ये सेशन चल रही है। क्या हुआ?
Someone's turned on their mic, please turn it off.
मैगी बना दो। लो।
Yes, we can go ahead.
Yeah, I muted, yeah. So yes, this is excitatory, this is glutamate. So what are the different types of receptors when we're talking about glutamate? I know the picture is a giveaway, but maybe this is a revision as well. Yes, NMDA. So you can see here, I've put it here, inotropic and metabotropic. That's the basic division that we usually have. And under the inotropic, you have the kainate or the MP, and the NMDA is the one which we all usually think a lot about and read a lot about because it has all those multiple sites. You have the glycine site, you have the site for glutamine. So the whole double process for the opening of the receptor, all of these are very important questions when it comes to the NMDA receptor, glutamate. Glutamate again is the master key. So the whole, it can, I mean, in its applications in terms of a question or this particular receptor is in so many places. Neuroplasticity is a question where very often this comes. Various disorders, you have the role of glutamate. Yes, it is excitatory, but even the steps of these, the how the receptor opens, the magnesium how it is blocked by the magnesium in the resting state. And then when you have all of these together, coming together is when the receptor actually opens and allows for the calcium to pass through. So all of this is all the diagrams that we have. This is from Stahl. This is for a simplistic I had taken it from an article on the internet. So in a simple way with this diagram, you can just explain the various sites and where it is, right? So the master switch is what generally we call glutamate. So these various receptors that you have, and the synapse is also shown over here. So a simple way to explain the glutamate receptors. This is a diagram which we included because we thought most this is related to glutamate only, the circuits of glutamate. And I think the confusion that most often happens, this is basically from Stahl, and it shows how the thing of when we say that there is increase in dopamine in schizophrenia, there is increase in dopamine on one side and there are positive symptoms, but at the same time, you have the negative symptoms and the cognitive symptoms as well. All are happening in the same brain. And why or how? Because generally, when we think about schizophrenia, what we say is a hyperdopaminergic state. So that is what this diagram has very nicely explained. Because if you look at the connections, when we are talking about the brainstem to thalamus, so the corticolimbic brainstem limbic system, striatolimbic system, which is there of dopamine, this is directly connected via the glutamate. So the job of the glutamate, if you look at here, is to, in normal situation, is to inhibit via the GABA. So this inhibits, because of which the dopamine is kept at a normal level. But what happens when there is a hypofunctionality of the NMDA, which is seen in schizophrenia, is that this inhibition is lost, because of which there is a overdrive of the dopamine, and hence in the limbic area you have excess dopamine leading to the positive symptoms. Whereas if you look at the functionality, when you're looking at the mesocortical areas, here it is more of a direct, there is an interneuron here, and here when there is hypofunctionality, this inhibition goes up, and you have what is a low or a lack of dopamine in the cortical regions, because of which you have the negative symptoms and the cognitive symptoms. So the same hypofunctionality, just because this is what, when I was telling you about GABA, I said GABA is a very tricky molecule, because some of it, most of it, if you see, it works through interneurons. So through an interplay of glutamate, GABA and dopamine in the same brain, on one hand, you have a hyperdopaminergic state in one circuit, whereas in the other circuit in the cortical areas, through the same three receptors but a slightly different arrangement, you have a hypodopaminergic state, because of which you have negative symptoms and cognitive symptoms, right? This is again from Stahl, very beautiful description as well. You can always go back to it and read if this was a bit too fast, because we are rushing due to lack of time for a bit. These again are all the neurotransmitters that we've come in. So I am moving ahead. This is serotonin, right? And the various regions. So simple ways, this is from Stahl. This is something that I had drawn again. So just a simple way to remember. And again, these are all like cards that I had made at the time of, because neurobiology is something which is very, very volatile. Basic science is something that all residents, because day to day when you're in clinics, when you're in OPD, you are constantly reading or you're interacting with patients. So clinical symptoms, the molecules, names of drugs you remember. But then this understanding is something that you need to keep with you, but something you don't visit often. So sometimes the terminologies, the locations get confusing. So if you can make like small cards or you of these diagrams and just keep revising them whenever you get time, it is something that can be very helpful for you along the lines also. So just like receptors, you have the various neurotransmitters. So they also can be long questions in themselves. So their circuits, anybody, which circuits are these? I think we just saw it in a previous diagram. If you can identify. This is again from Stahl. I think when it comes to understanding, yes, dopamine, neurotransmitter and ये Stahl का दूसरा कोई तोड़ नहीं है. The very simplistic way in which he explains. I believe all residents must read at least the major chapters from Stahl once, because the conceptual understanding that it gives you of the way the brain functions in terms of neurotransmitters is very, very useful. So yes, you have the all the various circuits, the mesolimbic. This is labeled, right? So you have this is, yeah, this is the circuit that we were talking about, the mesocortical, which is what we saw for the negative and cognitive symptoms of schizophrenia, right? So this again is, like I said, Stahl, dopamine pathways. So very quickly, we gave you the three neurotransmitters broadly, which you can go through, and all the neurotransmitter diagrams, including histamine, glutamate, are all there in Stahl. You can definitely go through. This little one here is our tubero-infundibular pathway, which is the one which is responsible for, सर ने जो बताया था कि ये हमारी गलतियां हमको बताता है, बेसल गैंग्लिया. This is again something. So when we give, yes, prolactin, and increased prolactin that happens when we give antipsychotics is essentially this pathways. Blocking of D2 receptors here is what results in hyperprolactinemia. So it's not, our nigrostriatal pathway is here. So if you can see this pathway which is there, the B and the C are more of symptoms, whereas A and D are more of side effects. So just with one, this diagram, not just the pathophysiology of schizophrenia, even when you're talking about EPS or side effects to show which areas are affected, you can very well utilize this. Okay, Saili, over to you.
Yes. What are we showing here? What are these two diagrams? So these are, I'll be moving ahead because of lack of time. So the left one is typical antipsychotic receptors it is targeting, it is shown. So basically D2 receptor, M1, H1 and alpha-1 receptors. So all the, as Madam now explained about the dopaminergic pathway, the mesolimbic pathway overactivation is leading to the positive symptoms. So typical antipsychotics, they are very good at managing positive symptoms, but while doing that, it also cause side effects because of the reduction of dopamine in other pathways like nigrostriatal pathway or mesocortical pathway for that matter. So all the side effects which are related to all the typical antipsychotics block all the all the D2 receptors throughout the brain. So so what should we do? What is the solution for that? So we want a molecule which would reduce dopamine but does not alter much the dopamines in other pathway like nigrostriatal pathway or mesocortical pathway or the tubero-infundibular pathway. So atypical antipsychotics specifically do that with their action on 5-HT2A. Along with 5-HT2A, they act on other serotonin receptors as well, like 5-HT1A receptors or 5-HT2C receptors. Along with that, receptors as well as alpha-1 receptors. Accordingly, they have their own side effects and the better effects as compared to the typical antipsychotics. I would advise to go through the stars again for the mechanism of action in details. They have given very vividly and very nicely about through the diagrams and of each of antipsychotics, atypical antipsychotics. So with this, I guess we'll move ahead. Um, yes. So here we are showing the life chart of BPAD specifically, and there are different yes, it is an Akascal classification. We are showing different episodes. The in between line is the middle one is euthymia, above that is mania, and below that is depression. So the upward curve is mania, downward curve is depression. In between mania and euthymia, there is hypomania, and here at last is an oval structure which represents mixed episode of BPED.
Perfect. Perfect.
I think one more
The
is
right one is
dysthymia is one that usually we
yes,
draw in the
yes.
long. Yeah.
Yeah. So dysthymia would be in between the euthymia and depression. So it won't be in between euthymia and proper depression. So the right one is the flowchart of our own patient. Here we are showing multiple episodes of mania, showing the treatments she has received or the specific symptoms we come across during her illness. So likewise, you can just chart down your patient's history on a chart. That would be more visually easy other illness, but for BPAD, it would be easier to chart it down. Okay. With this, we'll move ahead.
Just as an addition here, generally we consider this, the x-axis would be the time and the y-axis generally goes for the severity of symptoms. So based on the chart that Saili has very nicely put here of her patient, what you can see here, for example, is the August 23 symptoms of mania would have been more severe than the September 22 symptoms. So just at one look, so this even in your practicals, because when you have patients of bipolar, it is very difficult to sit and write your past history in full depth and detail. So just one chart, sometimes even examiners just say, just show the life chart, because they also know that you do not have the time to really write so much. So in just one picture, you can just represent everything in one go. It becomes very easy for you when you're presenting, and it is also easy for you to see things at one go and talk about. So medications also you can mention, severity of symptoms is there, frequency of episodes. So I think Bhave sir is asking, is it a rapid or a non-rapid cycler? So even that you can represent right here from one diagram, right?
I guess, yes. So this chart is showing response, remission, recovery, and then again relapse of the course of your illness. So referring to the previous diagram, this is in between line is euthymia. Their downward curve is suggestive of depression. At the very end, if we are starting antidepressants, then the symptoms improve. And when the symptoms improvement is around 50% or more, then we call it as a response to antidepressant treatment. And this we can achieve by your clinical observation as well as the skills which we apply for the uh, uh, treatment monitoring of the patient. So this is your response in depression. What is remission? Remission is when almost all of the presenting symptoms are recovered and they are for around they are recovered for a considerable time of period. That is a remission. That here downwards you can see the timeline. So if the remission persists for more than 1 year, then we call it as recovery. So this graph you can show in your theory exam as well as in your practical while taking the history of the patient, and you can just chart it out as a response to your treatment of the drugs. So different illnesses have different definitions or nomenclature for the the particulars for the response, remission, recovery, and relapse terminologies. So relapse is what? Relapse would be after getting recovered, patient would again go in depression. Okay, so relapse is the second episode of depression after recovery. Okay, so this is given in stars very nicely, vividly explained in the text. Okay, yes, ma'am. Now, what is this? The structures itself are suggesting of a circuit which is CSTC loop. What is CSTC? Cortico, striatothalamic, cortico loop. Okay. So CSTC loop is involved in multiple functions, including motor, um, behavioral, and reward. Yes, and the anxiety disorders also. The emotional part of it is in. So motor, as you all know, the direct indirect pathway also includes all these three structures. Here we are specifically looking into worries and obsessions related cycles. So it is related to your limbic CSTC and related to your emotions. So in conditions like you rightly pointed it out, OCD, stress, PTSD, then panic disorders, any anxiety disorder, schizophrenia for that matter, the loop, CSTC loop is seen to be hyperactive. Okay? And accordingly, we have to treat the patient with the pharmacological agents like benzodiazepines, then alpha benzodiazepines, SSRIs, uh, likewise, which will reduce this hyperactivation of the CSTC loop. So this is important in your theory exams as well as your practical, explaining the OCD and other illnesses based on the CSTC loop. Yes.
Like paracetamol is हर मर्ज की एक दवा, वैसे sir has said this is हर मर्ज की एक diagram. So one
Exactly.
diagram for many.
Many disorders.
Yes. So this one here is the right one is very familiar diagram to you, showing VTA, that is ventral tegmental area, then nucleus accumbens, your frontal cortex is shown, and substantia nigra is shown. What is it? It is a reward pathway. Reward pathway, yes, it is a reward pathway, and in the left one, it is shown more vividly and more, in a more and biological way it is. So the chart, the diagram shows addiction in 3 steps, like binge, that is intoxication, then withdrawal, which is associated with
Is Siley audible?
Her connection is unstable, I believe.
symptoms like stress, anxiety.
Hmm.
Riley, we can't hear you. You're gone on mute.
Hello. Yes,
Ah.
ma'am.
Yes.
If your connection is unstable, no, maybe while you're explaining, you can turn off your video so that the audio connection will be clear. We lost you somewhere in the middle of binge intoxication and
Okay.
preoccupation. Yeah.
Yes. Okay. Uh, so binge intoxication is the first few consumption of substances where the patient gets reward or pleasurable feeling after consuming the substance. Because of that, he or she would consume the substance again to have that pleasurable feeling again. So the next one would be after continuous use of the substance, he or she would experience negative features, anxiety, withdrawal symptoms, and other dysphoric features because the substance has been stopped now. So to gain that substance, patient would try and get that substance in any possible way he or she can. So that would be his executive functional disparement. Okay. So these in the brain diagram, they have shown three colors. The blue one suggests the basal ganglia, which is responsible for your reward system, which include nucleus accumbens and your ventral tegmental area. Then the red one or the pink one is your emotion related structures, that is amygdala and habenula, which will make you experience all the emotions related substance. And the green one is prefrontal cortex, which is related to your executive function. So executive function mainly is craving and achieving, procuring the substance in spite of knowing the harmful effects of the drug. So this is a reward pathway and addiction explained in a single diagram. And this
Just
is
adding one thing, this we put a reference here. This comes from an article highly recommended by DMD Addiction. He said this is something very, very conceptually sound, good for you to understand reward pathway as well as neurobiology of addiction. So please do go through that article and on your own time. It would be very helpful.
So it is, this one is very again simplistic diagram. When you don't have time in an exam, you can just put your key components in your brain diagram, that is nucleus accumbens, your hypothalamus, amygdala, and ventral tegmental area as well as the prefrontal cortex. Moving ahead, we'll,
Yeah. So this is
yes.
something that I learned when I was in KEM under Shilpa ma'am's during my bond, and something that we used to every week keep repeating because we used to. This is something very, very helpful when you're explaining the model to patients as well. Any idea? Yeah, biopsychosocial is one way, but this essentially came from epidemiology. This is actually the illness model that we talk about, or the disease illness model of diseases. And usually in KM, when we would explain it, it had the chart had the diagram of the host, and then the agent usually was a mosquito, and the environment was the messy water. So and then the next chart would have the host, the same person, but the agent would be, the mosquito would be replaced by the bottle of alcohol, and the environment would be replaced by all the social cues and the peer, the socio-environmental things, occupational stress. So it's a very simplistic way to remember and understand how, when you're talking about substance use, all these factors play a role. So it's not enough that you just go and tell a patient that you stay away from alcohol or you stay away from the substance. There are many things within the person whether we're talking biological in terms of genetics or neurotransmitter changes, especially when there is chronic substance use. We saw the previous cycle, right, of the reward circuit. Over time, that circuit in itself undergoes a lot of changes. So that change in itself also is responsible. Along with that, you have the psychological factors where you look at the various personality traits, a person's life experiences. So all these factors you need to take into account. Similarly, when you're looking at the agent, you have the different means of procurement of the agent. And it's not just the substance, but it is also a lot to do with the socio-environmental factors. So you have the environmental cues, you have the peer pressure, you have the occupation, you have things within the home. All of these factors need to be taken into account. So one diagram, multi-use. You can use it to explain to patients. You can use it to very in short put down the various factors associated with substance use disorder in your LAQs, in your answers, and for your own understanding when you're dealing with patients. What all factors I need to take into account when I'm doing management. This is also something that you can use. So this is thanks to Shilpa ma'am. This is here. This again is related to the previous two slides. What is this? I think someone is trying to say MI. Elaborate, please. Stages of change. Yes. Can anybody tell me who gave this quickly?
Prochaska and Di Clemente.
Yes, thank you. Always appreciate whoever that was on came on mic. Can you just quickly tell us your name?
Dr. Vidhu.
Dr. Vidhu. Thank you. Thank you. I wish more of you would interact on the mic. It's always more helpful than reading chats. Okay, so yes, this was given by Prochaska and Di Clemente, and this is the stages of change: pre-contemplation, contemplation, preparation, action, maintenance. You may have a lapse, but that does not mean it is the end. So lapse is just the first time that after abstinence a person may have consumed a substance. From lapse, the person can very well go back into action and continue in maintenance if intervention happens at the right moment, right? That's why you have this arrow here, that they can very well go back into maintenance. But if there is no intervention at that point in time, the person may go back to their previous pattern of substance use, which is what would be relapse, in which case, again, the stages keep going up and down. So this is a very dynamic model that we have. Very useful. It's not just for substance use, but it is in terms of stages of change about various aspects, any kind of behavior, motivation, even for in cases of obesity, where we are talking about taking of drugs, where we are talking about lifestyle changes. This is very, very applicable. And in practicals also, usually you're asked when you're presenting a case of substance use that what is the stage of change of this patient. So it's expected that you know these definitions and these stages and how you move with it when you're talking about motivation enhancement therapy and the motivational interviewing. Yes. Saili, I think this is over to you.
What is this? What is this diagram? Can anybody please tell? With the
Circadian rhythm.
right. So it is a circadian rhythm showing suprachiasmatic nuclei and the retina and the retinohypothalamic tracts. Yes. Moving ahead, as you all know, when the light is perceived on retina, it is conveyed to suprachiasmatic nucleus through retinohypothalamic tract. So there, in retina, there are intrinsic photosensitive retinal ganglionic cell which are sensitive for the light, which are responsible for carrying the light stimuli to the suprachiasmatic nucleus. So what happens between the retinal cells and the suprachiasmatic nucleus? So there are two different neurotransmitters in retinal cells. They are excitatory and inhibitory. In excitatory, there are two types, that is glutamate and PA-CAP. Okay. So these two excitatory neurotransmitters, they help to they are then released into the synapse, and after getting received at postsynaptic neuron, they help the influx of calcium ions into the postsynaptic neuron, and which in turn activate the CREB. What is CREB? It is CAMP responsive element binding protein. So after entering the after the entry of calcium channel, there is increase in CAMP levels, and that activates the CREB in the postsynaptic neuron. The activated CREB then binds to uh, the CAMP responsive element, which is located in the DNA, and then in turn starts the expression of genes called PER1 and PER2, which are responsible for the resetting of biological clock at suprachiasmatic nucleus. So suprachiasmatic nucleus cells, they reset the clock according to the light perceived in the surrounding, and they then again help in resetting the peripheral clock of the body, that is heart, lungs, liver, stomach, your adrenal glands, kidneys, and other organs. So how do they do that? The suprachiasmatic nucleus, they regulate that clock in periphery through neuronal control, that is sympathetic and parasympathetic pathways, as well as some hormones like glucocorticoids and melatonin and orexin. So we have taken this diagram from an article again, and it has very vividly explained about the circadian rhythm in details in that article. So here what is important? It is important to know how they are the suprachiasmatic nucleus work to reset the biological clock, which is again implied in your conditions like a phase delay or phase advanced disorders of sleep. Uh, what was the
Somebody had
comment?
mentioned chronobiology, so that is where this overall this entire process would come.
Yeah.
Circadian rhythm, yes, various sleep disorders, and in terms of management also, this is the aspect. I think sir has asked a question in the chat. People can read and keep on replying while we move on.
Yes. So next diagram is diagram of adult brain waves. So as you all can see here, it is arranged in a descending order of frequencies. First one is beta waves with frequency of 14 to 30 waves per second, and then then there is alpha waves with 8 to 13 waves. Theta waves, they are 4 to 7 waves, and delta, that is less than 3 to 5 waves. So here on left side, they have also shown the activities of brain and the waves which are seen in the different stages of consciousness. So while we are awake and mentally active, there are beta waves which are active. And if EEG is done, then beta waves are prominent in the picture. So awake and resting, awake but resting. Eyes are closed and we are awake. We are not asleep. So they are alpha waves which we can come across. So during my residency, our seniors used to say eyes on, alpha gone. So when you open your eyes, the alpha waves would be gone and beta waves would be taken. Would take the charge. Okay, during sleep, then while initial few stages of NREM, there would be theta waves which we come across, and in the deep sleep, then delta waves are recorded on the EEG. So I hope you are thorough with the brain waves. Here also quick the order-wise mnemonic we can say BAT D, we used to remember it as in a descending order of frequency.
The frequencies are a must to remember, whether it is you're seeing the EEG and in your practicals, most of the people in OSCEs or in the stations, you do have EEG as one of the things that you need to interpret. Many of you during residency also may be actually reporting or going through EEGs. So it's a very simple way to remember. Of course, you need to keep age in mind when you're thinking about these waves in normal. So what Siley was talking about is normal adults. In children, you would
Hello.
see up to, yeah, in children up to a
Hello.
certain age. I'm not going to say which age that I want you to read. Delta waves are normal. So after a certain age, you will start finding alpha. So you go back and read that also about normal, which waves are normal at which stage. Right. Siley?
Yes. So, in continuation, we'll also be looking into the architecture of sleep here. So, this is a sleep cycle shown in this figure. This is also given in CTP or Leishman organic psychiatry textbook. So, it starts with awake stage of consciousness with low voltage, high frequency waves, that is beta waves. Then, while we fall asleep, it starts with the NREM stage of sleep, and there are four stages of NREM, that is stage 1, 2, 3, and 4. So first stage of NREM has mixed frequency voltage uh, waves. Then when we go into the deeper sleep, we go in uh, stages like stage 2, stage 3, and stage 4. Stage 4 is the deep sleep, and it is the last stage of NREM. After that, patient goes into REM sleep, and REM has again the mixed waves which are recorded on the EEG. According to the stages, NREM first stage has alpha waves, and then NREM stage 2 has particular structures. They are called K complex, which is shown in the right side figure, and sleep spindles. So in stage 2, you will come across all these phenomena on the EEG, and that is brain waves. And stage 3, then again in a deeper sleep, as we seen in brain waves diagram, the delta waves, they appear. Okay. So then after that, the REM stage starts. After REM stage completion, patient tends to fall again into NREM and again into REM. This is a cycle of sleep. Okay. And then after, as we come closer to our awakening, then REM cycle breaks into awakening. So this breaking into awakening is regulated by multiple things like body temperature, the hormones, and other regulations. And this again is awakening. So REM is also associated with muscle atonia, so as uh, mm, to identify the stage of the sleep. So that cycle and associated sleep disorders like parasomnias or dysomnias are very important to understand from the perspective of sleep disorders, and they are very vividly and nicely given in CTP as well as in Leishman. Leishman I would prefer for sleep disorders. It is given nicely in Leishman organic text of psychiatry. Yes.
This diagram always helped me remember or understand. We always say, no, that REM stage is the paradoxical, because if you can see the brain state, it is almost as similar to the awake state. But the body in REM is where it is in complete hypotonia. There is complete loss of movements except for the eyes. So that state or that difference is quite obvious here if you're looking at the waves, if you're looking at. And again, the sleep study, all of these various disorders, this would come into play. Moving from sleep to, oh, yes, another towards the end disorders that we go to. What is this? Though there was a jhalak, but you can quickly tell me. Sexual response cycle, yes. And which is whose? Male, female? Rao sir has his own very nice way of explaining this. He says generally for the men, you need to think about like a flush tank. The water fills, it reaches, and then you flush and it's gone. And then for some time it takes for the flush tank to refill again. Dr. T.S.S. Rao is our resident IPS at this point in time, for those of you who don't know. He's in the incoming year. So sir is very known for his lessons on sexual medicine. So male is where he describes that way, whereas female he would say is like istri, our istri iron box. Takes time to get hot, but once hot, stays that way for quite some time until there is a resolution. So this is a sexual response cycle, slightly different. Of course, you can see ABC. It's not that it's going to be the same way each and every time. There can be variations. This is from our own synopsis. It's there, the diagram is there. So you can see the variations also in every person. This is what we explain to patients also, no? That sometimes there may be excitement. If you see B, there may be excitement, but it doesn't reach up to the stage of orgasm, and there can be resolution. So each of these, this is generally for men and this is in women. So this is the sexual response cycle, very important when you're talking about the response, various sexual disorders. Of course, with ICD-11 now it's become a different chapter on its own. It's come out of the mental and behavioral chapter, but something that definitely we need to understand and know. One more graph that is here. This is, where do we associate these words? Yes, ECT waves, sine wave, brief pulse, ultra brief pulse, right? So this is all associated with ECT, and this would be a very simple way. So electroconvulsive therapy in itself can be a question for you, or you can have questions about the various other methods, non-pharmacological or biological methods of treatment or intervention. So these two are very useful diagrams to have with you there. So the different types when you're talking about, so you have the modified, unmodified ECT. Similarly, you have the brief pulse, ultra brief pulse, with the difference that you can see very nicely here in this diagram about the time duration that the pulse is delivered for. So this is a very simple diagram that you can utilize when you're describing this. Similarly, you have the different electrode placements as well, no? Bitemporal, where is the placement exactly, at what location? This is for the temporal, this is for the frontal, right? So simple diagram which can explain this. This is for ECT, okay? And I am rushing through to the last one because it's almost gone beyond 11:30. Anybody? So someone talked about flowcharts at the beginning, right? So a very good utilization of flowchart is especially when you're talking about management of various disorders. So this we have actually taken from the clinical practice guidelines given by Indian Psychiatric Society. This is for sexual dysfunction. This clinical practice guidelines is freely available online for people logging in from India. On the IPS website also you can get, Indian Journal of Psychiatry website also you can get the connections. Wonderful, very brief short. So this sexual dysfunction one is something that I have read during my residency also. So instead of sitting and writing management for pages and pages, so beautifully in just one diagram you can see they have conceptualized the entire thing of how you can manage. So similar things are available for depression, for schizophrenia. You can even basically make changes in this as per your individual. So many a times nowadays in paper, you are given an entire case and then asked to discuss differential diagnosis and how you would manage the case. So rather than writing so much, if you just put down a flowchart, which you can customize as per that patient's or that case. You can put down everything that you would want to evaluate. See, you can see here what all would they would want to do as assessment based on the answers or the assessment. If the answer is yes, what they would like to do. So even your differential diagnosis you can put in just one diagram. So just as a representation, we have used this flow chart here. So flowcharts are also very useful form of diagram. So you saw diagrams of neurobiology, you saw for reward circuit, you saw various table or tabular form. Flowchart is again one more form that you can use. Do go through the clinical practice guidelines, because that's what all my teachers have told me. You're practicing in India, you must know what the Indian scenario is or what are our guidelines. Yes, you have nice guidelines, you have CanMat guidelines, all these are also there. Good to know everything, but you must know the IPS guidelines as well. So with that, yeah, these are most of the references that we have taken, other than the few specific ones that we put, are from these standard textbooks that we do use during residency. And with that, I think it's over to you, Saili.
Yes. Okay. So, thank you, ma'am. Now I guess I'll conclude the session with vote of thanks. Okay. Uh, I thank Dr. Sudhi sir for his encouragement and constant support throughout this academic journey of ours. Thank you very much, sir. Our chairperson, Dr. Gawande sir, his encouragement and enthusiasm to conduct all these sessions make them very enriching and helpful for the PG students. I thank Dr. Sri Lakshmi ma'am for helping me figuring out the PPT and also finalizing the final PPT. And
Saili, Bhavesh sir
yes,
would like to say something.
sure.
No, I must say I'm extremely happy with the session. I mean, it was really illustrative, very, very helpful. I must confess that I got revised in many of my own concepts, which are slightly getting rusted. Just one small point. I mean, one interesting point was the identity of the mystery Wonder Woman. I mean, just like in the Wonder Woman series for film,
She's
I mean,
Rishita.
she's a mysterious lady. So, so the same here. So thanks, Ritisha, for telling us that you're from Sevagram. And congratulations to Wonder Woman. I mean, because I think she answered so many questions correctly. So, yeah, I mean, it was a very, very educational session. Thanks to the subcommittee.
Thanks a
Yes,
lot,
and
sir.
I
Thank you,
would
sir.
request Saili, to all students, please take printouts of all these diagrams, paste it on your study table or the wall attached to that, and please read every day. Okay, just putting them or pasting them would not suffice. Go through it when we take a cup of tea, or like when we get up in the morning. Go through all those 25 diagrams. That would help them on a long term.
Reason why we put
Sure,
in
sir.
hand-drawn diagrams was also that just looking at it in the book would not do. This is something that you can very well draw in your own way and practice.
And Bhavesh sir, a courtesy for those hand-drawn diagrams is Dr. Sri Lakshmi.
Oh, yeah.
Some are Saili's and some are mine, sir.
Very nice. Very nice.
Okay, sir.
Uh,
Thank you all of
Actually,
you
yeah.
for the students also. I think they've 1.5
Pardon,
Yes.
sir?
years.
did we have a
All
record attendance this time? I mean, I could see 140.
147. 147.
Wow. Is it a record for this subcommittee?
No. It was 197. Maybe second session 197 was there.
So this is the second highest, I suppose.
No, I think 197, 177. Third highest, I would say.
I think in any case, I think this committee's programs are being attended most. I mean, I don't see any subcommittee in the West Zone which has comparable
So
figure.
much.
Yeah.
we must thank our residents for that, sir. Without their support, I
Yes.
think
It's
none
not
of this. I
possible.
think many of them shifting to Sunday, many of them have said has helped because they have some time to attend. And there are many
Yes.
more, I think, who do also. For those of you, please pass on to your friends also that all these recordings are available on the YouTube channel of the Psychiatric Society West Zone, which is there. So even if you want to go back and watch again as a revision, You can even download the videos and keep to go back. I think you all have your marrow and all your videos that you've been doing during your preparation. Similarly, you can go back and refer at any time. That is going to be useful for you. Thank you
Yes.
so much.
So thank you so much to our past participants also for being so wonderful and interactive audience for us. It made our experience more uh, pleasurable. So with the permission with seniors, I'll like to conclude this session. Thank you very much. Have a good day.
Bye. Good day.